most the parents that will get our test are just going to get a negative report. It's not risk scores. It's not insights. It's we screen these genes. You did not have a variant of interest. That's fine. Great. It's a good exam. But for about 8 to 12% of parents, they'll get a positive report, and it'll be a variant in this gene. The best case is we're able to treat diseases before symptoms ever develop, and you can delay the onset of symptoms indefinitely through proactive management.
Matt, Kyle, thanks for hopping on today's podcast. Excited to speak to you guys today and learn about your work at For Genomics. First, can one of you get us started, actually both of you, with your backgrounds and what led you guys to start For Genomics?
Yeah, so I'll start with my background, and then it really transitions nicely into why we started For. So started my career in life science investment banking, was fortunate enough to get a project with an idea called the New York Genome Center. This was back in 2010. Sequencing was Human Genome Project was completed. More people were being sequenced, but we were starting to see these large studies where you would take a few thousand people with a disease, sequence all of them, try to understand how genetics may impact disease. So I spent about a decade at the New York Genome Center, helped launch it, recruited our initial faculty, grew to about 250 people. We were sequencing 40,000 samples a year. For personal reasons, my wife and I came back to San Diego, did some consulting, and always had this idea that we were so focused on genomics for adults when in reality, your DNA doesn't change throughout life. And so what you really want to be doing is understanding DNA at birth. One thing led to another, consulted for a couple IVF clinics that were going through acquisition, got more familiar with the NIPT market, the carrier screening market, newborn screening. And there was this obvious gap between what could be done for kids and what was currently being done. And the whole medical system was delayed until someone was sick. And so decided to launch For Genomics. Now we've got a product in market. So I'll pass it over to Kyle now.
Yeah, so, similar to Matt, had a start in science. I didn't go the financial route to life science, but, I studied microbiology, and that was the background. And moved out to San Diego, with wanted to, had a hope and a dream. I wanted to do something in biotech. I wanted to be able to golf year round, so it just made sense to move out to San Diego. And worked in genomic sales for a while, kind of the same time frame that Matt's talking about, 2009, 2010, 2011s. Sold next generation sequencing to these research labs, to these contract research organizations, and enjoyed it, and learned a lot about the research world. And, really the more and more I got into it and, spent about 10 to 15 years doing that, I realized I wanted to be on the clinical side where I can really make a difference. And, research obviously is important, but, it's oftentimes I don't get to see it myself, move on to the clinical side of things and help humankind. So that's kind of what led me here. Matt had this hope and a dream himself and put it in front of me, and it just made a lot of sense. The helping out humankind and the longitudinal aspect of catching this early and really being able to build out a whole longitudinal health plan for children for their whole life just makes sense.
Yeah. That's fascinating. I love how you guys were both doing similar types of work, but from different angles. You, Matt, from your work with the New York Genome Center, and then Kyle, you were working in genomic sales, and it made sense that you guys came together and to tackle, whole genome sequencing at For. And I'm not sure if it's relevant, but I think it's very relevant, but I don't know if you guys saw the news the other day of it was the first time that they developed a gene editing drug, specifically a CRISPR drug to treat a child's unique mutation, and genome sequencing confirmed that the child had a rare genetic disease. And then I think it was a doctor created a drug, a gene editing drug designed specifically for the baby. So this happened, I think this week. It was published on The Economist, other news articles. And so it's all the buzz right now, and I'm sure there's going to be more of these stories in the market, right?
It really is. The best analogy I heard was your DNA is kind of the software and your body's the hardware. And so they had to go in and fix the software. And it was a great example of what can be done by understanding your DNA. In that case, that kid was a NICU baby. It was an ultra rare disease. It wouldn't be something that we find more pediatric onset, so ages 2 through 20. But the same approach could be done where you go in, you repair the mutation, and then you've got a healthy outcome moving forward. So we're really excited about the advancements on the biopharma side to bring these technologies forward.
Yeah, spot on. And before we get to pediatrics, I know that's a big area for you guys. Can we talk a little bit about like why hasn't like whole genome sequencing made its way into like routine care? Like what's broken today, or maybe like it's not, the word's not broken, but like, what hasn't it made its way into like routine use?
Yeah, I'm happy to take this one. I'm curious what Kyle has to say, but unfortunately, I think we're going to look back at the period over the last few years as a enormous loss of data at the expense of saving money. And so, if you look at whether it's cancer testing, whether sequencing tumors or diagnostic testing, they're just looking at a fraction of the genome. They're just looking at genes of interest, and they're discarding everything else prior to sequencing. But that everything else could be very valuable, whether it's driving the cancer, whether it's causing a disease. And so we really took the opposite approach and said the costs are coming down for whole genome. They're finally, a couple of years ago, this would have cost, thousands of dollars to do. So it was, cost prohibitive on one sense. I understand why they did that. But why don't we start with the whole genome? Let's sequence everything, and then let's just look at the area of interest. So it's almost, a targeted panel, but we start with sequencing everything. And so I think that really is, and then you've got the whole genome sequenced. If you do need to go and, as new gene disease validations are made, or if the child gets sick and you need to interrogate different parts of the genome, you've already got that information sequenced and stored.
Yeah, right on. And very interesting.
To Matt's point, I do think initially it was cost prohibitive, and now I think a lot of it is just people are not necessarily wanting to adopt it because they don't want to change. There's these processes set up. There's the pull down menus in these doctors' offices where it's just like, this is the panel, this is what's easy, this is what I can do, this is what's covered by insurance, right? And so it's a lack of education both on the consumer side of things, the patient side of things, and on the provider side of things as well. And so that's what we're really trying to tackle is the education aspect of this as well, showing how powerful it can be both to the patient and to the provider and what you can do from there.
Yeah, spot on, guys. It is a technology that's been around for like decades now, it feels like, but like you said, it's looked at from like a specific type of test, like a cancer test, sequencing a specific type of tumor, but the secret sauce is really in looking at the whole genome, and like you said, the cost of that has come down. So now it's about educating providers on that. And with that in mind, like, I want to talk a little bit about the work you guys are doing in the ped space. From what I understand, like, Fore is really tackling, gaps in pediatric care, or educating peds providers. I think I saw you guys are like active in like 250 plus clinics, and so how does you guys have like this pediatric health exam, from what I understand, right? How does that work? And like, what makes it different from other genetic screening approaches in the ped space?
What our genetic health exam covers is it's whole genome sequencing. So we sequence all 22,000 genes, but then we only look at 817 genes for 864 conditions. How we choose those conditions is a process, but it boils down to, would it be helpful for the parent and the doctor to know early in life? And about a quarter of what we screen for are metabolic conditions where your body can't process or over processes certain things. About 10% are neurologic, 10% are cardiovascular, the rest are across other systems. And the whole idea right now, every child, depending on the state you're at, gets newborn screening. It covers a few dozen conditions, and it usually is focused on the first. Newborn screening covers really diseases that happen in the first or second year of life, but there's a lot more than that. And so right now, the current healthcare system is set up as a diagnostic test that's post-symptomatic. And if you look at any of the research behind that, it's about 5 to 7 years between initial symptoms and diagnosis. And it's not because genetic testing is not, it's not moving. It's high enough in the clinical workflow. It's a lot of times these symptoms might appear as elevated liver enzymes or something that could be associated with hundreds of different diseases. And so doctors kind of say, go home, come back in 6 months, and maybe then we'll order a test. And so what we wanted to do is, even though, most of the parents that will get our test are just going to get a negative report. It's not risk scores. It's not insights. It's, we screen these genes. You did not have a variant of interest. That's fine. Great. It's a good exam. But for about 8 to 12% of parents, they'll get a positive report, and it'll be a variant in this gene. And then it comes with, this is what you need to know, and this is what you should do about it. And in the best cases, we're able to treat diseases before symptoms ever develop, and you can delay the onset of symptoms indefinitely through proactive management.
Yeah, and Matt, on that level, it's funny that you use 8 to 12% as that number right there, because 8 to 12% is the prevalence of diabetes here in the US, right? And with type 1 diabetes specifically, there are drugs that you can take pre-symptomatically, so before stage 3 diabetes, before there's any symptoms, right? That can delay the onset or maybe even avoid the onset of symptoms altogether. So there's a drug like Tzield that you can take, and nobody, unless there's a family history, nobody knows that they're susceptible to having type 1 diabetes, right? So that's one of these things that you can look at these 6 different diabetes genes that we have on our panel, if you will, and you can see, hey, I have a susceptibility to type 1 diabetes, and now suddenly this drug that can help avoid, stage 3 diabetes is available to you because you are pre-symptomatic and you know that you had this predisposition.
Yeah, interesting. It's almost like, it's like being, if you're a parent, like being proactive if your child, of like, getting screened for this early on, so that, later down the road, God forbid something pops up, you at least know about this ahead of time.
Oh, absolutely. And even on a smaller scale, it's something like hereditary fructose intolerance. So, there's one gene that shows that, and it's exactly what it sounds like. Your body can't metabolize or process fructose or other certain types of sugars, sucrose and sorbitol, I think, right? So as an infant, even with the formula, if you are, using formula, you can look for these ingredients that you want to avoid in there. Hey, I have this condition, this HFI. I need to find this infant formula that doesn't have fructose, that doesn't have sucrose, that doesn't have sorbitol in there. And it's a very basic thing that you don't know to look for unless you know to look for it, right?
Yeah, spot on. You guys said like 10% is like neurological too. Like I know this from my background, but a lot of like neurological conditions and diseases actually pop up in like your 20s, like a lot of common ones, like schizophrenia and like bipolar disorder, like a lot of those pop up later in your life, like even beyond pediatric age. So like if you can get an understanding of that ahead of time, like, man, there are certain lifestyle things you can do to be in a better spot when the day does come, like.
Yeah, and
Absolutely.
what's interesting about some of those disorders is sometimes they're symptoms of other diseases. And so I think as we sequence more people, we'll see that there's the root cause might be different than what we're currently calling a disease. The reason we expanded neurologic conditions, it's not every type of autism, but a good percentage, north of 50 types of autism, have a defined genetic biomarker. So we've included all of those in our test. I actually think that as more research comes out, we're going to find that most cases of autism, there's a genetic predisposition and there's an environmental trigger. And so we're really interested in that. We're doing some research. This is kind of why we do the whole genome, is so each year we can go back as new research comes out and update these reports for parents. So it's kind of an annuity that grows as the child ages.
Yeah, we're seeing the previous conversation where I talked about my background and it being on the research side of things. There is $6 billion spent annually on clinical genomics research, right? So there's obviously some solutions and some findings every year that are coming out with new gene disease associations. So in using whole genome sequencing as our backbone, we're leveraging that $6 billion that are spent every single year on this.
Yeah, spot on, guys. Yeah, that's fascinating. I mean, the fact that you guys are able to update these reports annually as new research comes out is fascinating. And like you said, you guys are looking at the whole genome. I think, Matt, you threw out some big numbers, like 812 genes, 816 conditions. I might have botched that, but the point is, like, it's over 800. It's a holistic picture,
When we started, it was about 300, and then it's really interesting. There's not really a good process to go to say what's everything we should include in this test, and so we usually go with a thesis. And so I was talking to the Glycoprotein Foundation, for example, and we were screening for 9 of the 15 genes that they're interested in. So it was like, okay, we can add those other 6. Let's throw them through our filter and say, is there enough clinical evidence to add? Or even an ophthalmology pharma company reached out and they said, are you screening for these conditions? And so did some work with them to make sure we added the genes of interest that were associated with their drugs in clinical trials. So it's an ever expanding list. I think that we're just scratching the surface. I don't know how big it grows to, but it's a really interesting process to go through to try to define, what do we screen for and why do we screen for it in kids?
Yeah, no, and it's clear you guys are expanding your the scope of your genetic health exams, especially like you just threw out the couple of those partners that have approached you or you guys have approached them. Can you tell us a little bit about the real world impact you're seeing with both parents and pediatrics clinics or pediatric providers? Have there been stories that have surfaced there that have been really telling to you guys?
It's a great question. It's so funny when we have these conversations with pediatricians because I would say at first they don't quite understand how we fit into their practice. It's kind of like, so which kid should I send to you? What should their symptoms be? And then the more you go, it's like, oh, this is for everyone. And then they go a step further and they say, so do you screen for this condition? I just made a diagnosis. The kid's been sick for 2 years and we ran all these tests. And it's like, yeah, that's what we do. If that kid had our screening done 2 years ago, you wouldn't have gone through that process. Or they'll say, do what about pharmacogenomics for this medication? Well, I just had a child where I prescribed medication and it didn't work. And it's like, that's also included in our test. So
Wow.
it's like Kyle said, we kind of built this with a commercial focus. The technology is there, but it's not being utilized. And so we want to educate physicians and parents that you have access to this. You can advocate for your healthcare. And these tools are available. They're still too expensive, but they are available. And, I think they're worth every penny.
Yeah.
And to elaborate a bit more on that, Bert, too, on the physician side of things, a lot of physicians are apprehensive to, add this into their portfolio just because it seems like it's a lot more work for them, right? But in all honesty, it makes their job significantly easier. You can help avoid these diagnostic odysseys for these patients, these 2, these 3, these 4-year odysseys where these symptoms are happening, these symptoms are getting worse, this treatment isn't working, this treatment isn't working, just by knowing that there's this predisposition. And, again, a lot of physicians are apprehensive because they are not geneticists. They aren't genetic counselors, right? They're internal medicine physicians. And we have a team of genetic counselors that disseminate all the information. They work in tandem with these physicians to help them make the diagnosis, right? To help explain what this means. So that was something that was paramount when we created this product, was to make sure the information was disseminated by genetic counselors, because genes are scary. Genetics are scary, right? And there's still a lot out there. There's 22,000 genes in the human body. Humankind, we know what about 9,000 of them do right now. So there's still 13,000 genes that we don't know what they do, right? So that's really scary. Even by genetic counseling and geneticist standards, they don't know what's happening. So these physicians who aren't trained in it certainly don't know what's happening and what it means. So that's it.
Yeah.
Another aspect of the test is the genetic counseling support that these physicians and that these families receive.
Yeah, interesting. I was going to ask you, those genetic counselors provide the education and kind of the dissemination of results, not just the providers, like the pediatricians, but also the families, you're saying?
Yeah, I would say more so the families. The families can opt in the physician for these, but it is designed to be a patient-facing test result. Right. So it's not something that you'd be like, oh, what does this gene mean? What do I have to go look on ChatGPT, which is always accurate, right? Yeah. You have to go look on this to see if this is this, and it's not that at all. It's a very patient-facing clinical action plan that parents can understand and do something about, and physicians can use to help in diagnosis.
Yeah, no, it's spot on. That's a super fascinating model. And Matt, I want to go back to something you said earlier too, which is so true for a lot of, I think even pediatricians feel this heat, but I was talking to one of my buddies the other day who's a current MD in training, right? And physicians oftentimes are so pressed for time with their patients, they have to fulfill all this work and they're treating at the point of care based on the symptoms that are present there, right?
Yep.
There's this other side of the coin too, which is if you understand the predispositions of your patients and their whole genome, what did that give you a leg up in your diagnosis and your treatment plan for them?
Absolutely. And it's not just positives, it's all the negatives, right? So as you're going through that, it's, if you get 864 negatives, it's like, okay, we can rule those out as potentially causing symptoms.
Yeah.
And so that's really why we built this. It's something that I think, some point in the future, who knows if it's 5 years from now, 10 years from now, 20 years from now, every child will have their whole genome sequence at birth and it'll be used multiple times for healthcare.
Yeah.
And that's what we want to do is let's just bring that future a bit closer to today. And so kids can get benefit of this now.
Yeah, I mean, there's a lot of buzz in the market too, with like all like the 23andMe services kind of going away and that data, being disbanded. So I feel like not even just education for, pediatricians, but like the general market too, I think still needs to come around to the understanding of like, hey, this could actually benefit me. It's not just like the doctor in the picture and the genetic counselors, but there is going to come a point where all of us will have better access to technology like your guys's, where we can screen ahead of time and know our risk, like, and mind you, there's always going to be a percent of the population that's going to be like, heck no, like I'm never doing that. But like, I think overall, as we move forward, like there's going to be more of the population that wants it and understands it, and B, wants it,
Oh, absolutely. And
Yeah, yeah. I'm sorry to interrupt, Kyle, but I just mentioned this while it's on my mind. The 23andMe case is really interesting because they're selling SNP arrays and it's very consumer focused, and SNP arrays are maybe 1/10,000th of what we screen for in terms of bases. Actually, their technology's last gen, but base is actually sequenced by us. Our business model is not to sell the data. We could go that route. We could have, subsidized our tests significantly, gone out with a much lower price point, but that's not what we want to do. It's really parent focused, and there's a premium that's associated with that. I've been sequencing genomes for almost 15 years now. If someone's paying less than about $1,000 for a product like this, their data is likely being sold out the back door to help subsidize the test. So it's a price that you have to pay if you really are wanting privacy and security of the data. And that, it's kind of, when you start something, you say, what are our core values? And we really wanted to be parent focused and make a service for parents. And part of that is you don't make a service that's for, pharma.
Right, right. No, that's a really interesting perspective. Kyle, you
and
wanted to add something? Yeah.
we are also partnered. Privacy is very important. And I know you brought up 23andMe and they had these privacy violations and people are concerned about their data. So yes, to Matt's point, we are not selling our data. That's not the business model that we have. But also we work with a third party company to ensure that it's the highest compliance for security. And we are not getting hacked. Let's put it that way.
Yeah.
It's a very stringent security process that we follow. The way that the data is stored is very secure. We work with a third-party company who that is their bread and butter. That's what they do. This isn't data security that Matt and I built as we were building the company, right? We have the actual experts who built our data security.
That's super important with healthcare data. Yeah. And I know we've been largely talking about like the biggest barrier to adoption is like, education in this space. Clearly like you guys know a lot about it. You've been in this arena, but my question is like, what collection method do you guys use for your genetic health exam?
Collection method is the same. It's just a simple cheek swab. So it collects a few cheek cells. We can extract DNA from that. Where our process differs is they do what's called a SNP array. So they're looking at single nucleotides across the genome, but they're defined single nucleotides at multiple points across the genome. And I don't know how many they're looking at, but let's assume that it's probably 500,000 single nucleotides. It's a pretty inexpensive technology. It's something that you could do for maybe $100 a sample, $50 a sample. You could sequence tens of thousands of people to try to find some correlations. That's why it's used for ancestry, because then you can get a circle on the map and kind of say these people from this history have the same SNPs.
Right, right.
When we're doing whole genome, we're starting at base 1 and sequencing all the way to base 3.3 billion. It doesn't quite work like that, but that's kind of the idea. So you get all chromosomes, all genes, and it's the entire DNA for that child. So it's much more in-depth than 23andMe and much more clinical focused because you've got all that information now. You can actually use it clinically.
Yeah.
And size-wise, to Matt's point there, whole genome sequencing, the data is 110 gigs of just A's, T's, G's, and C's.
Yeah.
110 gigs of letters, right? So there is an immense amount of data in your body in the whole genome.
Okay, that's fascinating. Yeah, like you guys are really looking, when you say whole genome, you're not joking, from base 1 all the way to 3.3 billion. And like the report you get out of it too provides you more clinical information than just like, hey, your ancestry might be from these regions of the world, like we're talking like actual genetic markers and predispositions for conditions, diseases, etc. Things
Yeah,
that,
clinical versus novelty, absolutely.
yeah. But with all technology, novelty is how it kind of starts. It's like, and then
Oh,
we
yeah.
get mass adoption and actual clinical impact. So
And certainly not knocking any of those types of genetic services, And I know Matt has had his dog genetically sequenced. He has a mutt dog with
Yeah.
a bunch of different breeds. So like now he knows these suspected breeds that Eddie is.
Yeah.
That's hilarious.
It's great.
Yeah. Please, let's just not get to a world where we live in like a Jurassic Park. We're starting to sequence extinct versions of beings, because we could get there one day too,
I think we might already be there, Bert. But I'll keep my mouth shut on that one.
We are definitely there. We are definitely there. It's cool though. It's kind of a funny thing because you bring up privacy and security. So people inherently then understand that this data has value and your DNA does determine your future health. And so with that understanding, then you've got to work with someone that's trusted to interpret what that means. And the earlier you can do that, the better. So that's what we're really trying to do as a company. And I think that technology's proven. Now it's, how do we educate people that this exists and then earn their trust to, work with us on analyzing their genomes.
Yeah. And I want to ask you guys, what are you guys doing like specifically to address this like problem of education? Like what are the methods you guys have like found that work well with pediatricians, other providers, like partners, like in doing this type of education? Is it just conversations like this? Is it a type of a handout, or is it actually just doing like a sample run or showing them, hey, here are other sample like genomes we sequence and the impact it's had? Like, what are you guys doing?
I think it's all the above, Bert. Everybody learns differently and everybody takes in information differently. So I think all the above are, useful education tools. And to be honest with you, we're still learning how to educate people as well. That's been the biggest challenge of getting this business up and running. It has been the education side of things. We built a good product, we built a fantastic product, but now we're still in the education phase. And certainly we have revenue and we're making sales, but through more education, we'll have more sales and more people will be benefiting from a really life-changing product.
Yeah.
And I think what we wanted to do was we're kind of still in a beta launch phase. We process orders, we deliver results, but wanted to get some initial data that we could build case studies around. We've got that data. I won't share it here because it's still, we're working on interpreting it. But it really builds the use case on why you'd want to do this. And when parents see that there's these other kids, although it's low likelihood, some of these diseases are 1 in 10,000, they're rare. So, you can take your chance and you're probably going to be fine. But when you collect, put them all together, it's a bigger risk. And so that's what we want to do is highlight a few of these examples. These kids are seemingly healthy until they're not. And so this isn't like my kid's sick, I need a test. It's more of a, your kid's born, you do this because you want to give them the best, healthcare possible.
Yeah. That's super fascinating. Yeah. And that's not spoken about enough, by the way, in the whole like marketing and sales world, just like looking holistically, like it's case studies sell, right? Like the moment someone, like, let's just say you put yourself in the shoes of a parent and you've learned about another child that had, this whole genome sequencing done and they were able to discover something that then ended up helping that child. Like you're more inclined to like trust that. Same thing with the pediatricians. If they hear about other examples of peds clinics that have benefited, and have had patients that this has helped, it becomes an easier conversation too, Yeah,
I think it's like anything, we're expecting in July. And so choosing a pediatrician is you kind of pick one that aligns with your values. And that's where, you could see this getting broad adoption from pediatricians because it aligns with parents' values and being proactive about healthcare versus reactive. And you're just seeing a trend. Our target market is 30 to 45-year-olds, and you're seeing a lot more investment in healthcare by that cohort. And so we think that the natural next step is investment in their children's healthcare, and kind of laying the foundation for a healthy life.
Yeah. And those 30, 35-year-olds are that's like kind of like the next boomer generation. I don't think we have the
Yep.
data yet, but yeah.
Whoa. Did you just call me a boomer, Bert?
But we're going to get, I mean, it's all the COVID babies, right? Like just saying how it is,
Yep.
right? So
yeah, it really accelerated the opportunity for us to do this is people getting comfortable with at-home healthcare, telehealth. You still get a clinical grade product, but you can get it from the comfort of your home and online. But I would say in some cases even better. There was a study out, I think it was even today, where clinical quality from telehealth has proved to be the same as in-person clinical quality. So it's pretty, it's encouraging that, then it makes it more accessible.
I'm sure there's studies on this on adoption curves of like technologies, but there comes a point where, like you said, it's a novelty, and then we move to adoption, and then clinical. Like at some point, there's clinical efficacy and effectiveness is proven, and then we all start using it, and then it becomes confidence.
Yep.
It's like
you just have to catch the bleeding edge, audience, the people that really believe, that love the tech, that know that it's the future, right?
Yeah, spot on. So yeah, I mean, for like the folks listening, like potential partners out there, other pediatricians, and thinking, I'm curious to learn about whole genome sequencing. I'd like to use this. This is what I'd like to try out in my practice or specialty. Like, how do they engage with you and your team online?
We're a lean company. You can go to our website, foregenomics.com. Both Kyle and I are on there. Our emails are Matt@ForeGenomics and Kyle@ForeGenomics.com. We actually both answered the phone, the number that's on our site. So
Nice.
We're pretty easy to get in touch with if someone wants to reach out to us. And if any parents are listening, it's easy to order. We try to make this, just as an example, I got my appendix out a couple of years ago, and then scheduling a follow-up appointment. It's not easy to go in and see a doctor. It takes time. I've got an issue with my shoulder. And so, sometimes you're booking appointments 3 months out. By the time that the doctor's schedule aligns with your schedule, people are busy traveling for work, etc. So you can order online. You can collect the sample at home, send it to our lab, and schedule genetic counseling around your schedule. So we try to make it really easy to work with us.
Yeah, I mean, you love that when both founders are available by phone, and you guys have made it easy for parents to order and collect the sample, arrange genetic counseling. And it's been a pleasure speaking to you both today. I definitely will keep tabs on your guys' journey, and excited to see how Fore, evolves over the coming months and years. And I'm sure we'll be seeing more press releases and posts from you guys in the market. So we'll have to, stay in touch.
Absolutely. And thank you for giving us a platform to talk about this, and for the invitation, Bert. Really appreciate it.
Yeah, right on.
Thank you very much.
Thank you.